Hi friends, I welcome you all for this session.
This part 4 of our placenta series is about VASA previa, which is a silent thread that we come across. Let's refresh the basics of a few things that we are going to discuss about placenta and cord insertion. Marginal cord insertion is defined as cord insertion site within 2 cm from the placental edge. In marginal cord insertion, the umbilical cord root is covered and protected by Wharton's jelly, and the umbilical vessel branches are in tight spirals and are inserted directly into the placental parenchyma. So as such, the marginal cord insertion does not increase the abnormal perinatal outcome because the umbilical vessel branches are tightly packed as well as protected by the Wharton's jelly. But it is possible for the marginal cord insertion to progress into furcate cord insertion and sometimes into velamentous cord insertion too. In the case of marginal cord insertion, based on the distance between the cord insertion site and the placental edge, it is divided into two categories. One is close proximity, where the distance between the placental edge and the cord insertion is less than 5 mm, and if it is more than 5 mm, it is considered as long proximity marginal cord insertion. Now, the cord insertion site can also be classified subjectively based on its location within the uterus. For this, we have to subjectively divide the uterus into 3 zones longitudinally, and then as upper, middle, and lower third. If the cord insertion site is visualized in the lower third of the uterus, then it becomes lower cord insertion. When the insertion is located in the upper and the middle third of the uterus, it is called normal cord insertion. Now let's see what is furcate cord insertion. When you see the last strip of images, you can see that the vessel starts to separate and branch before reaching the placenta. This is the hallmark of furcate cord insertion. Even in the gross specimens, you can appreciate how the umbilical vessels branch outside the placental surface and are no longer protected by the Wharton's jelly before entering the placenta. This loss of Wharton's jelly covering makes these vessels highly vulnerable to compression or rupture, especially during the labor. This slide beautifully shows the spectrum of abnormal cord insertion, starting from the marginal cord insertion on the left side, progressing to furcate in the center, and the filamentous cord insertion on the right side. Marginal cord insertion is the mildest and carry very little clinical significance, whereas the filamentous cord insertion on the other side of the spectrum has increased risk of VASA previa and cord accidents due to unprotected course of fetal vessels. So what explains this spectrum? There are two theories. One is polarity theory and the other one is tropotropism theory. When you see the line diagram given below, that explains the polarity theory, which is nothing but normally the embryo implants with its embryonic pole facing the endometrium, allowing the straight alignment between the developing placenta and the umbilical cord. But when the blastocyst implants obliquely, the embryonic pole faces away from the implantation base, forcing the umbilical vessel to extend towards the placental site, resulting in marginal furcate or even filamentous cord insertion. The second concept is tropotropism theory. In this, the placenta naturally tends to grow towards areas with better vascular supply and regresses from regions with poor perfusion. For example, lower uterine segment is relatively less vascular compared to upper uterine wall. So, when the placenta implants lower down, it gradually regresses from the poorly perfused lower segment and expands towards better vascularized upper segment as the pregnancy progresses. So as this redistribution happens, the cord insertion, which was originally marginal, can progress to furcate or filamentous cord insertion. So together, these two theories, polarities and tropotropism, explains us both the origin and progression of abnormal cord insertions. VASA previa literally means vessels in way before the baby. It refers to fetal vessels that run across or very close to the internal cervical os. These vessels lie within the membranes, unsupported by the umbilical cord or placental tissue, and therefore at high risk of rupture when the membrane break. The major risk factors for VASA previa are IVF pregnancies, filamentous or marginal cord insertion, resolving placenta previa, bilobed or subcentrate placental lobes. Interestingly, in approximately 11% of the cases, there are no risk factors identified. We must understand that antenatal diagnosis of VASA previa is life-saving. This is because the perinatal survival rises from 44% when undiagnosed to 97% with prenatal detection. Now, let's look at the types of VASA previa. Type 1 is the classical form, and it occurs with velamentous cord insertion where the umbilical cord inserts into the membrane and the vessels then travel freely before reaching the placenta. These unprotected vessels may cross directly over the internal os. So the key point in type 1 is single placenta with velamentous cord insertion. In type 2, it involves connecting vessels between the two placental lobes as in bilobe placenta or in succensurate lobe placentas. These bridging vessels often run across the os, creating the same risk scenario for rupture. Pathologically, this pattern is explained by partial atrophy of the placental tissue around the cervical os due to poor perfusion. Now the key point for type 2 is bilobed or succensurate placenta. Type 3 VASA previa is the least common one, in which there is generally a large curved or boomerang shaped vessel that runs along the placental edge. That is, it leaves the placenta, goes around the internal os and then return back to the same placenta. This generally results from the focal atrophy of the placenta. The key point in type 3 is it is a single placenta, although low lying, with a normal cord insertion. Therefore, identifying type 3 VASA previa can be particularly challenging. The only clue may be that it is a low lying placenta. Other than that, it has a single placenta with normal appearing cord insertion. Therefore, without a high index of suspicion, this condition can be easily overlooked on routine examination. Now let's discuss about the few practical points and essential steps to follow when screening VASA previa. First step is to identify placental cord insertion site in every pregnancy. A velamentous or marginal insertion is most significant finding in VASA previa, and careful tracing of the cord with color Doppler helps in the confirmation of its entry into the placenta. Next, evaluate the placenta to ensure that there is only one placental mass. If there is a bilobed or succensurate lobe is present, look for the connecting vessels and check that none of them cross the lower uterine segment. Transvaginal scan in these cases is particularly helpful, especially when the cord insertion cannot be clearly seen when there is low-lying placenta or placenta previa, or when succensurate lobe is suspected. Whenever there is any uncertainty or difficulty in evaluation, it is essential to utilize all the available ultrasound modalities beyond grayscale, including real-time sweeps, color Doppler, and especially pulse wave Doppler. These tools are invaluable in distinguishing whether the vessel is arterial or vein based on its waveform pattern. We will be discussing about these details further in the upcoming slides. In patient diagnosed with placenta previa or low-lying placenta during anomaly scan, it is essential to reassess the lower uterine segment later in pregnancy, both to confirm resolution and to ensure that there are no exposed vessels that are remaining in the lower uterine segment. Even in late gestation, the lower uterine segment can be clearly visualized by gently dislodging the fetal head during the transvaginal scan. If this is difficult, lowering the maternal head position can further help the fetal head to move slightly out of the maternal pelvis, allowing for the clearer view of the lower uterine segment. When the gestation age advances, the stretching and elongation of the lower uterine segment takes place, and therefore it is not surprising to see some cases of VASA previa resolving spontaneously as the pregnancy advances. You come across any circular structures in the shape of a bubble or any tubular structure which is hypoechoic, we should suspect VASA previa, and you confirm by using color Doppler and also the pulse wave Doppler. We know that in case of velamentous cord insertion, the vessels fan out from the cord insertion site and enter the placenta in several different places. So in such velamentous cord insertion, we will be able to see a cluster of vessels in the lower uterine segment, which will run in different directions before entering into the placenta. Sometimes, to visualize this cluster of vessels more clearly, it becomes necessary to use both transvaginal and transabdominal scan as they complement each other. This is because the vessels fan out in multiple directions, and depending on their angle relative to the ultrasound beam, some of them may not be detected on a single approach. So far we saw how to suspect VASA previa. Now let's look at the evaluation steps once the suspicion arises. When we identify a vessel coursing near the internal os, our next step is to determine what type of blood flow pattern it represents. Is it arterial or venous? If the flow pattern is arterial, then there are two possibilities. One is it could be a maternal blood vessel, or it could be a loop of cord called funic loop, which is seen close to the internal os. If in case of maternal blood vessel, the waveform will be pulsatile, but the rate of the pulse will be in synchronization with the maternal pulse. Also, maternal blood vessel will remain fixed in location, and it is usually located along the lateral uterine wall rather than over the internal os. Whereas, if you sample a funic loop, it will show high velocity pulsatile waveform in synchronization with the fetal heart rate. But the vessel will move freely with the fetal movements, and in the case of change in maternal position between scans, you can find out that this funic loop also changes its position. When we suspect a VASA previa and when we sample the same blood vessel, and if it turns out to be an arterial flow, then funic loop and maternal arterial blood vessel are the differential diagnosis. Now let's think about if it is a venous flow, then how do we differentiate? If the flow pattern is venous, then we need to differentiate from maternal venous channel. As you see in the figure ADG, the maternal veins will show fluctuating flow varying with maternal respiration or pressure changes. Fetal veins, on the other hand, show a constant steady waveform completely independent of the maternal breathing. Some of the other common differential diagnoses are uterine artery or venous varicosities, amniotic bands, chorioamniotic separation, or the placental edge sinuses. All these mimics can appear as a linear or tubular structure near the cervix on grayscale imaging. And in such cases, color Doppler and pulse wave Doppler are extremely helpful to differentiate. Therefore, if the vessel shows an arterial waveform pattern that matches with the fetal heart rate, and after excluding funic cord, then it is likely to be a true fetal vasculature, confirming the diagnosis of VASA previa. Whereas if the flow is venous and there are no nearby fetal arteries, we should carefully trace the vessel to identify its origin, and if necessary we need to repeat the evaluation, and even it may be necessary in some cases to obtain a second opinion to confirm the diagnosis of VASA previa. Now let's look at why the distance between fetal blood vessels and the internal os is so important. Any unprotected vessel that lie within 2 cm of the internal os meet the definition of VASA previa and require cesarean delivery. Cesarean section is preferred in such cases because the risk of vessel rupture during labor is extremely high. Even during cesarean delivery, it is crucial to carefully visualize the membrane before making an uterine incision to avoid cutting through the exposed fetal vessels accidentally. An alternative and safer approach is to deliver the baby and call with the membranes kept completely intact as shown in the picture, and then rupture the membranes only after the neonate has been safely delivered. Now, when the unprotected vessels lie between 2 and 5 cm from the internal os, the risk is obviously less. In these situations, women should be counseled about the potential risk of rupture and offered the option of cesarean delivery, although there is no consensus regarding this. Therefore, if a vaginal delivery is being considered in this 2 to 5 cm zone, then Labor must be managed with continuous fetal monitoring, and delivery should take place in a center capable of performing immediate emergency cesarean with appropriate NIC isotope. Suppose if the vessel rupture accidentally, it should be managed. Fetoscopic laser ablation or FLA is one of the upcoming options for selected cases of type 2 and type 3 VASA previa, where the exposed vessels can be clearly seen and accessed. FLA is best suited for type 2 and type 3 VASA previa, where the exposed vessel is a part of succinturate or bilobe placenta, and they are clearly visualized and can be accessed easily. Whereas FLA in type 1 VASA previa is technically very challenging because we have to ligate the vessels that are running between the cord and the placenta. So the exposed fetal vessels may be too close to placental margin, making it too difficult and risky to ablate the vessel safely. Also, performing FLA between 31 to 32 weeks of gestation can not only safely prolong the pregnancy, but also it improves the neonatal outcome significantly. The systematic literature review by Dr. Ruano has shown that there is technical success rate of around 98% with 100% neonatal survival and giving around 50% of vaginal delivery. So this procedure can be considered as a potential option when the facilities are available. According to Society for Maternal Fetal Medicine, there are clear recommendations on how and when to evaluate patients with placenta previa or low-lying placenta for diagnosis of VASA previa. First, during second trimester ultrasound, we must document placental location, and specifically we should describe the relationship between the lower placental edge and the internal os. And whenever technically feasible, placental cord insertion should be documented. Now, if placenta previa is diagnosed in second trimester, and even if it later appears to resolve, or if low-lying placenta is identified in either second trimester or in third trimester, then definitely a follow-up transvaginal scan becomes mandatory. This follow-up evaluation should be performed between 28 to 32 weeks of gestation and must definitely include both color and pulse wave Doppler to rule out whether it is VASA previa or what, to rule out the existence of fetal vessels. In short, whether placenta previa persists or resolves, and whether low-lying placenta is seen in second trimester or third trimester, every such patient must undergo another transvaginal scan at 28 to 32 weeks along with color Doppler and pulse wave Doppler, so that we don't miss a case of VASA previa. Dr. Zhang and his colleagues have proposed two-stage screening protocol for VASA previa that brings together both first trimester findings and second trimester placental assessment. Stage 1, it is identification of high-risk pregnancies. This stage 1 screening is performed in both first trimester and also as well as in anomaly scan. In first trimester, we should document umbilical cord insertion, whether it is central or marginal or velamentous insertion. The central insertion is a very low risk category, whereas the velamentous insertion comes under the high risk category. From 20 to 22 weeks anomaly scan, we should assess the placental location, and low-lying placenta or placenta previa becomes high risk category, whereas the placenta situated in the normal upper or mid uterine location becomes the low risk category. So in stage 1, velamentous cord insertion from first trimester and low-lying placenta or placenta previa in second trimester are grouped under high risk category. Now stage 2 is where actual diagnostic test for VASA previa happens, and all patients belonging to high risk category from stage 1 will undergo transvaginal scan with color Doppler and pulse wave Doppler. Using this two-stage protocol in this cohort, they found out that 99.2% did not have VASA previa after proper targeted Doppler evaluation, and in 0.8% of the cases were confirmed to have VASA previa. In my personal opinion, this two-stage screening protocol is a very structured and logical way to screen for VASA previa. I would also like to add one more practical point from my clinical perspective. Even marginal cord insertion identified in first trimester should remain under our surveillance. Although not traditionally included in high risk category in this cohort, Marginal insertion can progress to furcate or even velamentous cord insertion as pregnancy advances. Therefore, keeping them under observation helps us to exclude even the slightest possibility of having VASA previa.
Thank you so much for watching. If you like this video, please subscribe and share to your friends.